Okay, we have expert number 2. He's in private practice, board certified in sleep medicine, pain management. You all know Dr. Mikowitz, and Dr. Mikowitz, take it away.
Thank you so much. When Lou approached me a week ago or so, it was specifically on internal derangements. So I'm going to take a little different tack. Dr. Malik gave us a really nice presentation of like the overview of like how you take a patient from point A to point B. And I'm going to get down a little more nitty gritty with you guys. And my practice is unique in a lot of ways because it is all I do. I stopped doing restorative dentistry, you know, for a multitude of reasons. I'm incredibly busy with what I do with the oral facial pain practices that I have. Sutter, Mercy, UC Davis, those are my biggest referrers for probably a 200-mile radius. So I get people from everywhere, and I'm like the person of last resort. I'm the neurological dumping ground from all of the local neurologists, the physical medicine specialists, a lot of the dentists, oral surgeons, I mean, whoever, and the dentists, of course. So, and I'm there, and I'm fairly available, email or whatever. My website, I left some referral stuff on my website back there. This is drmcdds.com. And there's a ton of information on there, links to, you know, all sorts of organizations, pretty much all the information that I can share here. And what's a little bit different about my approach, I mean, it's pretty much part and parcel of what they teach at UCLA, you know, in terms of how we get from point A to point B. You know, I'm a UOP boy, so, you know, we have a little different bent on things. But it was a similar background. You know, when I started this 25, 30 years ago with Dr. Chase down at UOP, and they had a pain clinic, and we had all the specialties represented, and it was pretty cool. But we didn't have the cool technology. We didn't have people like Dr. Rathi at our fingertips, and Dr. Hatcher, who are incredible assets to our community. So we have these incredibly complex patients, and we look at them, you know, like Dr. Malik discussed, you know, not just from the facial standpoint, but we got to look at the skeleton, we got to look at the airway space, we got to look at their brain, we look at their sinuses, we look at the cervical spine, and then we start peeling them apart. We did layer by layer by layer. The teeth obviously are important, the bone's important. To have someone do this, I can't do this. I mean, thanks to Craig for this video some time ago, Craig Dial over at DDI. Shameless plug for them. I have no financial interest in them, by the way. But this, you know, looking at the airway spaces is probably one of my fascinations. I got into sleep medicine, you know, way before it was cool, and pioneered some of the techniques and beta tested a lot of the appliances that you people use on a daily basis. So my world, you know, is like, why do I do what I do? You know, because frankly, it's much more profitable to do regular dentistry. I mean, infinitely more profitable. And it's getting harder and harder and harder. Everything that I do is billed through medical insurance. And for all of you docs out there who want to get into this business, awesome. If anybody wants to be a partner with me, awesome. I have no problem sharing information. People hang around my office all the time. I train the residents from UC Davis in sleep medicine. It's mandatory that all the sleep fellows spend 10 hours with me to learn about oral medicine and what we do and how we handle sleep patients from a dental perspective, which I think is pretty cool for UCD to be that progressive. But it's not for the faint of heart. You know, I have to have a full-time medical biller on staff. And if you're not prepared to do that, you know, maybe doing this full-time is not for you. Or maybe working at it part-time is for you. I have, you know, very highly trained assistants. And then I've taken it to another level because as Shika will attest to, a monstrous proportion of my practice is degenerative joint disease, to the point where it's almost epidemic in my practice. And I find that fascinating from many perspectives. Very female-driven, probably 98, maybe getting closer down to 95%, maybe down to 93% right now. I'm actually doing a study right now. We just pulled 100 charts random, and we're going to start looking at things. I'm going to show you a guy who's got some incredible DJD later. So I look at these cases a little bit differently than most people because I get the worst of the worst. I don't get my job pops and clicks, you know. I don't get that. I get them maybe 6 months later or a year later when they're locked out and they're in tremendous pain. And so my world is a little bit different. And so I titled this thing, you know, because it's an internal derangement. That's what we're talking about today. That's what was my topic, was, you know, because it's Halloween, as things that go bump and crunch and grate and pop and lock and grind and all that stuff. all these incredible sounds that these patients come up with and their descriptions that they have, and they're all really important. And each one of them means something to me. You guys brought up stethoscopic examination. I don't use a stethoscope anymore. I have joint vibration analysis. I don't use that very often unless it's a medical legal case. I do a fair amount of medical legal work also. But it just becomes a point after 40,000 patients, not making the number up. I mean, it's feel, and it's listening. And that's probably the biggest skill that we lack is listening and asking the question why. Why did that tooth break? Why is there, a crack on that tooth? Why is there pain? Why is there a headache? And when you start to dig into the whys of things, it makes you a better dentist, and it makes you a better doctor, makes you a better assistant, makes you a better hygienist. And a better front desk person if they got to answer the phone and answer those questions and triage these patients who have a half-hour story, because we give them an hour and they want to tell their story. They go to the physician, they get 7 minutes if they're lucky. So what do they get? Prescription. So we're a little bit different. So my world is more about things like creeping. Creeping has to do with how discs move in space and what happens to the hydrodynamic activity of that little piece of cartilage that we're so fascinated with measuring, and where it's going to be, in centric relation, and how we're going to manipulate the jaw. Is it bimanual? Is it this? Is it that? So we worry about that. It's a hydrodynamic force, and we're trying to measure this statically, and we're obsessed with it as dentists. We love to measure stuff. I'm not a measuring guy. I'm a touchy-feely guy. So we talk about creeping, weeping. Things weep. The fluid weeps out of these little hydrodynamic things like sponges, and depends upon the force you put on it. And there's different forces. There's torsional forces you got to worry about. And probably the most, and compressive forces, of course, if there's a traumatic injury of some sort, whether it be a car accident, a blow to the face, being cranked open, because, no offense to the dentists out there, but I will throw people under the bus. The trend towards cranking a person open with a rubber dam, endo, post, build up, crown preparation, 4 hours, one visit, numbed up, I think is a disaster. I think it's wrong. I know it's efficient, but I think it's wrong, because I think that you're asking that patient, and if you're not looking at those joints, yes, it's very efficient. Yes, you can make some money, but you're asking for trouble from that patient. And so it's been one of those things where I never got into that world, because it was all about comfort, and it's splint therapy first before I did that crown prep. Identify that problem, full mouth impressions, to make sure I've got everything, mount things up, face pose. I mean, and that was for simple crowns. So it's not like, sure, you can do, there's no such thing to me as a simple crown, and there's no such thing as a simple patient. And so everything that I see is I feel extremely complicated, and I treat it as such, even though they come in with like the slightest little poppy clicky thing, and they finally get to me after 5 months of navigating the medical system. They're in my chair, and it starts out, but when you get the story, it's like it goes on and on and on and on and on and on. And the whole thing about the sodomization disorders and cryptotrauma, where people suppressed sexual abuse and physical abuse. And there's so many fascinating things that will come out of these patients, and that's my juice. I've been doing this 30 some odd years, so it's a world that I have chosen for a reason. And so if you want to get into this world where you worry about tumor necrosis factor alpha, and you worry about interleukins and cytokines, and when it comes down to it, everything that we deal with, I don't care if it's heart disease, cancer, TMJ problems, a cavity, everything we deal with is an inflammatory process. And that's where we're moving towards. So there are tests now that are available. Ghazal published this last year. You can do a urine test and with a 98% specificity, find out whether or not they have sleep apnea off a $20 urine test. That's where it's going. So all this stuff of bringing home sleep study tests in the office, I just spent $5,000 on one just last week. But bringing all this stuff into the office, for me it makes sense, because I do, I'll see 5 to 7 new TMJ patients every day, and maybe 3 to 5 sleep patients every day, new, plus all my ortho patients, plus my orthognathic patients. So I'll see 30, 40, 50 patients a day, not uncommon. I'm working on 2, 3 operatories. So I'm a busy guy. And so you've got to be on top of this stuff if you want to enter this world. So I'm going to let you enter into my world. And basically, because of the nature of the beast, the disc, once it's destroyed, it's destroyed. And you'll see some examples of that in great detail. There's 2 really famous movies out there. One's called The Yoint, which is these incredibly boring Swedish guys, and I have it on my other computer back there. If you just YouTube The Yoint video, it'll put you to sleep. It's a really great sleep aid. But just listening to their voices. But the diagnostic work that they did, which was fresh cadaver dissections, was pretty cool. The one that I'm going to show is done by Dr. Tanaka down out of Scripps, and it's fairly old, but it's much more detailed. Similar thing, and I'm just going to let it run. And so this is the Tanaka video. This is your normal joint. So orientation, real quick. There's the head of the condyle. There's the temporal fossa, glenoid fossa, posterior attachment apparatus back in here. There's the disc, the biconcave shape that's well described. Boom, boom, fat, skinny, avascular zone right here in the middle, very, very thick fibrotic tissue. Back in here, look at all this soft, mushy stuff. I mean, what? Go ahead, I'm listening.
Doesn't show. Here, use mine.
Oh, okay. Thank you. Red is so much better. Okay, so I believe we moved on to a degenerative disc. So looking at the difference with this little perforation right here, and you can see this is the anterior portion we're coming out here, this posterior portion of the joint. And as the disc pops back and forth, you can start to see right in here, that avascular zone right in there. So when you start to load this joint and you start to worry about what you can do about doing a crown, a simple crown on someone like that, and how this changes so much because the weeping, the creeping happens back in here as that tissue flops back and forth. And these are fairly fresh cadaver dissections. I mean, Tanaka has a pretty cool setup, or he did at least. It's like people die, they've donated the body to science. He gets them first, and he goes and he grabs their head, chops it off, slices them up, and he does this. And he's an amazing guy. If you've never heard him speak, he's really a gem. But looking at this avascular zone, and we get so fascinated about, I'm going to do bimanual manipulation of a jaw, and I'm going to find this perfect centric relation position. Well, what the hell is centric relation on this person? Look what this tissue going to the inside. What is that? Look at this. He's pulling this. He's kind of bending the head of the condyle out. This is the most common thing. This is your popper clicker. Okay, you just click right there. All right, there's the head of the condyle, fossa, muscles, superior fibers of the lateral pterygoid there, attachment apparatus back here, and you can see as that little pop and click right in there. But look how it just all jams up in here. So what's happening to this soft tissue? How is this changing the shape, and it's getting fat here again where it should be avascular or was avascular before? That's the seeping and the creeping and the viscosity of that fluid that's inside of that joint changes depending upon the force that we put on it. And so, we get so fascinated, I'm going to recapture that disc. How many times have you heard that one? And everyone's got this fascination with recapturing the disc. And you'll see in a minute why you cannot recapture a disc. There are situations where you can do plication. Saw a young lady right before I came earlier today. We'll watch this one. I might stop it after this one for a sec. So this is posterior attachment apparatus, posterior part of the disc. You guys are going to be really good at this in no time. Head of the condyle, probably some arthritis there because it's really flattened off. Fossa, muscles out here. Now all of a sudden, watch what happens to this disc. Where does it go? Bank, disappears. Where'd it go? It's behind the screen somewhere. It's magic. And it's going to pop right back out again. So when a disc displaces, when it pops and clicks, almost invariably it's going to go anterior medially. because of the pull of the fibers. It has no other choice. So when you think that you can recapture that by taking your anterior repositioning splint and moving that jaw forward and putting it right there, and you've captured it, and you open and close, and you have someone who pops and clicks, and you say, put your teeth edge to edge, open and close. Okay, does it pop and click? No, I don't hear any sounds. Okay, perfect, I've cured you. But now your teeth are edge to edge. Maybe that's where you need to be. Maybe, maybe not. So that's why we do splints, that's why we put them in, diagnostically. So this disc displacement, to try and recapture that, you really can't try to force this back into place because of the dynamic of that soft tissue. But we think we can do it. How many times have you seen it? And so how many lectures have you heard? And how many articles have you read where you think you can do, and gurus who are out there who will tell you that this can be. And you know who they are, I'm not going to name them. You watch what that thing does, and when it goes medially and all the sounds disappear, you think you're a hero because all the sounds went away. Well, guess what happened? The disc is permanently displaced to the medial, permanently displaced to the anterior, and you're functioning on some sort of scar tissue. And that's fine. That's perfectly fine, as long as you recognize that's what you're on. So limited opening, so the disc is stuck right there, and he can't go any further because, again, the hydrodynamics of it. Imagine this is a feather pillow, okay? And you're looking at this is some of the feathers, and this is some of the feathers back here, and this is the middle, and you got your hand in the middle. You put a grapefruit in the middle of it. So it's like this three-dimensional figure eight, and it's draped over the top of that. You hit the feathers on one side, they're all going to go to the other side. That's what's happening here. You're hitting those feathers or smashing into the back. But periodically, because of the hydrodynamics again, and because of the thickness of the tissue that's in there, and because of the forces put on it, all that tissue is going to get stuck up in front here, and it won't translate any further. Or because the first part of opening is a rotational movement, right, 10 to 20 millimeters, and the second part of the movement is translation going down the fossa here. This is, one of our nice perforated patients. This is like my bread and butter right here, where there is no disc. They're bone on bone. So posterior attachment apparatus, disc tissue all bunched up here, fairly decent range of motion. Of course, disc tissue all bunched up here. So basically, it's fairly decent range of motion. It's come down to what we need to try to accomplish and what we need to focus on as dentists and as practitioners in this area, surgeons. If we were doing arthrocentesis, for instance, and much of this work came from Dr. Hatcher way back when, and Dr. Galley, I think you were in that office way back when, back on Folsom Boulevard. And Dr. Hatcher would go in, and he was a radiologist, and they used to do arthrograms on joints, and whenever there was something, and they'd look for perforations and all the things we just saw. And he was masterful at it, and then, so he put the little needle in there, he'd shoot the dye in superior compartments and inferior compartment under fluoroscopy, and then he'd take pictures of it. And then, oftentimes these people are put to sleep because it's not very comfortable to have dye shot into your joints. And you can see perforations and leakages, and he could read these things with amazing, this is way pre-cone beam CT. What they were finding was that just that activity, just flushing that joint, flopping it back and forth, the patient felt better when they were done. They can open fully. They just did an arthrocentesis, by proxy, and it worked. And as Dr. Galley, who's probably done more jaw surgeries, I would think, than anybody in Northern California, at least not California, open joint, closed joint. When was the last time you even did an open joint procedure?
About a year ago.
Yeah, so not very often. Arthroscopies, probably not as often. Arthrocentesis, bread and butter, because it works. And we have tremendous result with that. And this is the crux of it right here, is, understanding this disc displacement and this hydrodynamic activity of this little piece of tissue right here. And you're going to tell me that you can find that when you TENS a patient, and you're going to pulse them, pulse them, pulse them, pulse them, pulse them. And then you're going to take a bite record, and you're going to tell me that that's where the disc is supposed to be. So you can tell I'm not a big neuromuscular guy. So that's my world. And I'll get into what I do about it as we go on here. So we worry about this viscoelasticity of the joint. And there's different kinds of forces that can go onto this joint that can create problems. Compression force. Take a big blow. Car accident, sports is probably the biggest one we see. Young female, volleyball player, soccer player, basketball player. I can't count how many of these girls I have in my practice. And great athletes, low body weight, estrogen levels plummeted, and you see how much arthritic changes are happening in there. This whole concept of going from progressive condylar resorption, seeing prepubertal arthritis. Saw a 9-year-old today, female Asian girl who super high strung, athlete, volleyball player, soccer player, everything, you know, super achiever. Plays the violin at a weird angle, you know, and cute, great kid, anterior open bite, big red flag for me. When I see an anterior open bite, that usually means arthritis in the jaw joint, because you get auto rotation. As the muscles start to pull down, the front teeth start to come apart. This is why I'm a huge cone beam fan, all right? I think it should be the standard of care. Dr. Hatcher is much more polite about it. He thinks it should be the standard of excellence. And he has a vested interest. I don't have a cone beam machine in my office. I send out 5 to 10 a day, maybe, about. So I could certainly justify the expense. I don't have the capabilities to do with that cool little video that Craig whipped up for me several years ago, actually. And it's even better now, what they can do. And from an orthodontic standpoint, I'm sure you can attest to, you know, looking at impactions and a cuspid impaction and pulling all that stuff out. And do you have a cone beam in your office?
We don't. But I use them fairly regularly for
Good.
impactions, craniofacial cases.
Great. So I do a fair amount of ortho myself, and so I do it on everything. I do it on Invisalign cases. To me, there's no such thing as simple ortho, as you know, you'll attest to. Everyone thinks, oh, it's a simple class 1 case, right? No such thing. And when you start getting into these kinds of situations, and I've bailed out a lot of orthodontists, and I'm glad to do it, because what they fail to recognize is they don't look here. Or I've bailed out many an implant surgeon, periodontists and oral surgeons who are getting what I call the cheater cone beams that just do the trough that comes across here because they want to see where the implants go. They go in and they do their implants. They do a beautiful job. The implants are lined up nicely. They do everything by the book, and then they go to do the restorations, and all of a sudden the bite's open. The bite's open the anterior, posterior, something's going on. Well, they don't look at the joints. And my thing about cone beam, and I'll get off of it after this, is that I'm not qualified to read those. I'm good, but I'm not as good as her, and not even close. And so I can look at them and I can do a pretty decent job, and I come up with some really crazy stuff, and once in a while I'll call her on something, or Dr. Hatcher, or we'll work on something together, because we see some very, very unusual things. The amount of calcified arteries, the amount of weird pathologies, salivary stones, masses in the brain, AV malformations. I mean, it's crazy the pathology comes with it. Maybe it's just my practice. Maybe it's just me. Maybe I'm lucky. The amount of arthritis, you know, you ask numbers, you know, arthritis versus myogenous pain. Probably in my practice, you know, maybe 60, 70% arthritis. That's huge. That's a huge number. And if you have a machine in your office, awesome. But pay the $70 and have it read. You know, have a professional look at it, because for a couple reasons. Number one, she knows more than you do. Number two, CYA. Because if you miss something, you're responsible. You have that machine, you miss it, you're responsible. If they have a vascular lesion, you're responsible. If they have something in their brain and you miss it and they have a stroke, you're responsible. If they have a pituitary gland tumor, you're responsible. AV malformation, you're responsible. What was the one we had? Something in their cervical spine, they had like a AV malformation in C1. Sorry? Chiari. Oh, yeah. Hell, I don't even know the names of them. That's what she's for. She comes up with the fancy names, you know? So it's like, you know, it's all this crazy stuff that you can see. You're responsible once you put that machine in your office. Great stuff, great technology. I think it's the future, obviously. So what am I looking for? You know, I'm looking for homeostasis. I'm looking for, you know, what, if you really want to get into this, you know, what's the alignment of the collagen fibers? There's several kinds of collagen fibers that are in that disc, and the alignment of those is going to dictate what sort of force they can handle and what sort of stresses they can handle. And the compressional force, the blow, we started with that. You know, the blow is pretty easy to understand and usually self-limiting, you know, unless it's really significant car accident, gunshots. I mean, I've seen all sorts of fun stuff. For the day-to-day stuff, you have torsional forces, you know, someone, you know, stretches too far to one side, cranked open for an endo, for instance, and they end up with a closed lock. Someone who sleeps funny on their jaw, and, you know, their jaw's off to one side, so they have more of a myofascial kind of activity in there, puts a strain on the joint. But it's the shearing forces that are creating the biggest problem. So when you have a shear against that articular disc, it doesn't handle that very well. So if that shearing force could be from a blow, basketball, elbow to the jaw, it could be from a crown that's not properly placed. It could be just a massive clincher grinder who's got all sorts of wear facets and wear patterns and dugout teeth. And it just boggles my mind how many patients I see today, just today, 8 new patients, and every single one of them had massive dental problems. I'm diagnosing dentistry right and left. I'm making guys rich. You know, it's like, you let me get you comfortable, and then you're going to go back to see your dentist, and you're going to get this and this and this and this and this. You're going to come up with a plan because, and here's why. And they're like, why didn't my dentist tell me all that? It's a good question. Why did my physician tell me that when I start talking about, you know, calcifications in their carotid arteries? Why did my physician tell me about that? And so these are the kinds of questions, if you're going to get into this world, that you got to have good answers to. Do I have all the answers? No. But as Einstein says, a good scientist knows where to look things up. So what did I look up last night? Because I thought this lecture was tomorrow. So quick search. These are just abstracts. I read all these last night. These are just abstracts on articles. Google, like internal derangements, TMJ, boom. Then I focus it down to abstracts. And lubrication of the temporomandibular joint. This is an old article. This is old school Tanaka stuff, goes way back to 2007 when they first started learning about hydrodynamic forces. They never thought about that stuff before. They never had the capabilities of making those measurements. This one just came out. It's a PhD thesis, biomechanical characterization of modeling and modeling of the human TMJ disc. I mean, that's, you know, pretty heady stuff. And it's that thick. So, and I will actually read that whole thing. That's what I call fun. So, so if you're not up on this literature, you know, this is stuff from 2000. This is just 2015, 2016. I narrowed it down, and these are just abstracts. So there's only, like, you know, 5 lines in each one. So there's so much information out there. But what I find fascinating is the information. Excuse me. The information is not coming from the United States. There's very little primary research done in the United States because of liability reasons, I'm presuming. It's from Turkey, it's from Israel, it's from Chile, it's from Honduras, the Philippines, you name a country, Europe, but not here, very little. So you gotta dig, you know, like page 27 of Google before you get to some good juicy stuff. So, moving on a little bit, there's other cool things we can do. Now, this is something we don't do much here, but they do this a lot in Japan because they have these machines and they care more. Is using functional MRI, and this is a little trickier to read, especially with the lights up. But there's the head of the condyle right there. The disc, I'm sorry, I'm in a bad angle here. The disc is right there. See it? A little bow tie right there.
Beautiful study.
So there's the bow tie of that little disc, and they slow it down. A little dance there. So normal, in quotes. Biconcave, just like we'd expect. So here it is without reduction. So the disc, you know, it's rotating, it's translating a little bit, but the disc is right here. It's all balled up right there. So it's not popping back over like it's supposed to, or gliding over. Things glide. They don't pop and click. We want things to glide. We like smooth. We like the tissue in here, when you start reading how thick, like even in a degenerative joint, there's a layer of these proteoglycans that are sitting on top of there that are so thin. So here's without reduction, so the disc is right there. And there's the head of the condyle right there. So MRIs, you got to read backwards. Black is white, and bone is black, and soft tissue's opposite. So this proteoglycan, this very thin layer of tissue, we're talking like 1 to 5 micrometers thick. That's nothing. But that's still there, even in a degenerative disc, in a degenerative joint. I'll pass one around. This is a 3D model. Again, thanks to Craig. This with our cool 3D printing that we can do now. So this is an actual patient. This is an actual joint. This is the actual head of the condyle. Okay, we got our orientation there. Condylar process, okay. So when you look at this and all this pitting inside here, that's what the joint looks like. That's the real deal. And this is the fossa, so hopefully you can figure out how to put this together. And you look at the lining of the fossa, and you can just feel it. It's one thing to see it, it's another thing to feel it, touch it, understand it, and understand that we want things to flow and to glide and to be smooth. And just like you want that crown to have good form, good function, good aesthetics. And all that comes from angulations and the shear force that you put on that crown. And it means something, not only to you as, you know, as restorative dentists and orthodontists, and, you know, getting everything to line up just right, and get good force distribution. When you have good force distribution, it's golden. This is really a physics problem. This is not a dental problem. This is a physics and engineering problem. And that's what we need to focus on. And we're so tunnel vision, you know, we get out of school and it's like, got to make money, you know, we got big bills to pay. And, you know, I was kind of fortunate. I did public health gigs. So I was 3 years in the public health service. So I was down in the desert in San Diego, and I had no one to help me. This is like, they hated me because I was competition to they're like one of the dentists in town. And it is literally one stop sign town in the desert. And so, you know, and this is before cell phones and the internet. So I'd be on the phone like, and looking in, you know, books. I'd see pathologies. I had no clue what I was looking at half the time. So, but I'd look it up and I knew who to call, and I'd call the endodontist, I'd call my buddies up at UOP, and I'd go read about it, and then I'd go back and I'd do the procedure. And, but you know, that's how you learn. And it was great because, you know, the patients were very, very grateful. They got great service. I worked ungodly hours, but it's okay. And I ended up having like 4 offices by the time I was done working with the public health. I learned a tremendous amount, and I paid off all my bills. I didn't have any student loans when I was done. So that was nice. But the average dentist coming out now with $300,000 in loans, it's pretty tough out there. It's a tough world. And dentistry is getting tougher, you know, for all the way around. You know, medicine's really tough. Dentistry is getting tougher, and because it's moving in the same direction. So not to scare anybody out of it, because it's still the most amazing profession in the world. But focusing on the engineering, and it translates not only to what we do from a TMJ standpoint and how you make your splint. By the way, shameless plug for Brabant. They make all my splints. They have for forever. And so they have a picture of my perfect splint, like what I want. And it's 99% of the time it takes me 5 minutes to deliver a splint. I don't sit there and grind on it. I don't sit there and have to polish it. I don't have any financial interest in Brabants, but a lot of respect for Kip and their team out here. Because they understand what I need, and they understand my standards, and they know better. If it doesn't look right, they'll call me and say, "Doc, these are lousy impressions." And I'm going to say, fine, I'll get the patient back in because that's the right thing to do. So, unusual presentation. Looks like a really healthy guy. He's 45 years old. Got a little bit of ortho stuff going on. A little bit of open bite starting right here, maybe. But overall, you'd think, good range of motion, not too bad. Lateral motion, pretty good. So what's going on? He's in pain. Things I look for, and I had them change my protocol a little bit at DDI. I look at neck posture. He's out here like this. So red flag, airway. Red flag, referred pain from the traps up into the masseters. I look at shoulder posture. He's sloping downhill to the left here. Something's going on. Something's happening with this guy who looks perfectly healthy and perfectly normal. So we start peeling him back, peel back the layers. This is part of that movie like we saw earlier. Looking at his airway space. Well, his airway is really not too terribly bad, when we measure it out. That's not why he came in, but I check it anyway. I look at their sinuses. I look at their cervical spine. Look at the steep angle of this jaw. Orthodontists are like, yeah, I see it. Okay. And then you start to see these little wings coming off here. And it'll show up probably better on the Ceph. So I get a Ceph on everybody. Why? They're not coming to me for orthodontics, but I want to know what's happening. Look at this little asymmetry right here. You see this, how these things don't quite line up on this lateral Ceph? You start to see this little flaring here. We can see the cervical spine, which isn't too terribly bad. Pituitary gland issues, sinus stuff we're starting to develop, angles of the teeth, endodontic issues. We're looking at all this stuff as part of our work up here. We get a pano. Now here's your real red flags. Look at this joint, okay? So this is his joint, and he's a little asymmetric. When you look at his midlines, tough angle here, but he's going off to the right here. And obviously, this is active degenerative joint disease. He's actively in pain. That's why he came. I'm in pain, my jaw hurts. Now, he came from his dentist who had a pano, who took a pano, and that same thing was on that pano. They didn't even mention it to him. They didn't mention it. And not that they need to treat it, but at least mention it. Periodontal disease, bone loss between here, tooth tipped over, adverse forces, shearing forces. Look at this. These are all shearing forces right here. So when you start to see these biomechanical problems developing, it's not just about what's going on here. That's not all I'm looking at. I'm looking at what's happening down here. Think of the adverse force with that vector coming down here and creating this bone loss. So we look at that. Dig deeper. Look at these big wings coming off here. This is where this little bend in this bone, right along here, where the attachment of the masseter muscle is. He's generating this huge bone density here, and he's generating 400 to 700 pounds per square inch on that little cusp tip. So what are the odds of that tooth fracturing? Pretty darn high. So bam, root canal crown. This is soon to be root canal crown. Then look at the quality of the bone. And this is one I called her on. It's like, what's going on with this guy? Because when I questioned the patient, he's osteopenic, which is kind of rare for a 45-year-old black male. That's really rare. And so I'm like, because I saw this, I'm like, huh. So I said, do you have anything else bone-wise going on? He said, yeah, they worked me up for osteopenia. Yeah, my hips. I'm like, wow. He used to be an athlete, he was a football player or something back in the day. So trauma, degeneration, osteopenia, osteogenesis imperfecta, which is not just jaws, it's all bones. And so that's what we're thinking is going on here, but that's a separate mechanism, I think, from the degenerative joint disease. Degenerative joint disease is more an inflammatory process. It's a load process. That shearing process has gone wild. And so once that degeneration starts in that joint, it's going to keep going and going and going until you stop it somehow, or it stops itself. In females, it starts off in progressive condylar resorption. In young prepubertal girls or precocious puberty is probably the biggest thing we see now. Young girls on BCPs for a variety of reasons when they're 8, 9, 10 years old, which decreases their estrogen levels. Gunson and Arnett did beautiful work on estrogen. If you haven't read it, read it. It's written in the Journal of Oral Surgery, 2010, maybe 12. Michael Gunson out of Santa Barbara did a nice study on the estrogen levels, and he looked at it in rheumatoid arthritis patients. And he had a population of approximately 24 females. I just had randomly one of my staff members pull charts, and we had 150 charts in about 4 minutes of young female with arthritis, active, in 4 minutes. So I got like hundreds of these people, these poor girls. But we get them better. That's the cool thing. They all get better. That's what I think is awesome. So we go deeper. We look at their sinuses. Sinuses look pretty good. And so then we start to section out the jaw. So this is with this splint in place. So basically what I'm trying to accomplish with this splint is pull this jaw down and forward. I mean, I don't use anterior repositioning splints, I don't use NTIs, I don't use Coys deprogrammers. I mean, I've used all those things, and I might periodically pull that out of my little bag of tricks once in a while. There's a great product out there called Sisu, S-I-S-U. It's if you're gonna do a boil and bite, it's a really amazing little product. It's like 25 bucks. Makes a great mouth guard. Put it over the braces for sports. Put it over the braces when they have a TMJ problem and they start popping and clicking. And what's cool about it is it doesn't slow the ortho down. So I inherit all these ortho cases that are disastrous. So it's like, well, let's just, I don't want to take their braces off. I don't want to slow that progress down. Let's treat it, do something, get the pressure off, treat it with medications, you know, trigger points. I do trigger points a little bit differently. We'll talk about maybe 5 times. But it's a really great product, SISU. And they have a SOSA or something like that, which is like a mouth guard. But what's cool is you can put it back in hot water and then it'll like flatten out again. You can put it back in their mouth and then form it again. So if they screw up, and it's not so thick, it's really thin, maybe 5 millimeters or so, maybe less. So it's really cool material. But so with this guy, with this, you know, this is a standard, you know, even contact, anterior displacement, you know, on the cuspids and cuspid rise, you know, whatever you want to call it. Simple, 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 simple. It doesn't have to be fancy. And in my hands, it works. I always make maxillary splints. Rarely will I make mandibular splints, only if a patient begs me to. It works in my hands. Soft splints shouldn't be made unless you're making them for football, or if it's like emergent, like I need something like today, and I'm going to wear it for 2 days, and I don't want them to go to the store and buy Dr. Bob's famous, you know, $25 splint they boil and bite, and they do it wrong. Like Dr. Bob's famous sleep appliance they can buy over the counter. So it's a similar thing. This is just where he is closed. This is just his without the splint in place. So he's not too particularly posterior displaced. And this head of the condyle is fairly well centered in the fossa here, but you know, there's not much fossa left in certain parts. It depends on where you look at it, and all this destruction is going on here. And it's all from the load issues. It's all from the shearing forces. It's all from the degradation and the inflammatory process that's going on in that joint. Interleukin, tumor necrosis factor alpha, that's what's happening in that joint. Cytokines, all these inflammatory chemicals. That's why our first line of defense is usually a non-steroidal anti-inflammatory. Throw some Motrin at it. Throw a muscle relaxer at it. You know, you got to break up the cycle somehow. I don't go into the joint very often. You know, cases like this, you know, come back a year from now, and you'll see this bone will fill back in. We use a protocol, the Arnett protocol, A-R-N-E-T-T. You look it up, Google it. Bill Arnett, he's a surgeon down in Southern California, orthodontic guy. He's got a huge protocol because they treat they get the worst of the worst too, but they're cash only and they're in Montecito, so they can charge whatever they want, right? So they got it made. So, but the basic protocol that we use, and it's on my website, you can look it up, but it's calcium supplementation, omega-3 fish oils, vitamin D supplementation, magnesium. That's the basics. You get a little fancier on a case like this, especially because I can get away with this with his physician, because I got to go back to his MD to get this approval, and plus I'm not a physician, but we will take this and we'll throw simvastatin at the patient in very low dose, which is an anti-cholesterol drug, which doesn't seem to make sense, but it works. It helps to bind zinc into the area and brings more bone into the area. And we use doxycycline in a very low dose, 50 milligrams twice a day. It helps to bind bone into the area. You got to be on it for a year, so they got to be willing to be on antibiotic for a year. And if you're down in Montecito, they'll use Enbrel or Humira, one or the other. One of those and you can die drugs, I call them, you know, because that's like the last thing they say when they do the ad for Phil Mickelson, like, and you can die. So, but it's a great drug, and you use it for a short period of time, for 6 months or so, and you'll take this arthritis and you'll make it go backwards. They do it on rheumatoid cases all the time. We do it on degenerative osteo cases. I've yet to get it approved up here by any rheumatologist, and I've got connections with every physician, probably several thousand of them, every ologist you can imagine in the greater Northern California area I can call upon. And I've yet to get one to do the Emerald because they don't, it's way off label use. And Montecito is $1,500 an injection, whatever. You know, they pay their gardener that. It's like, poop, okay. So it's no big deal to them. But they do beautiful work down there. If you ever get a chance to read some of their work, it's pretty amazing. So that's my world. This is what I do. This is how I live. You know, that plus the sleep medicine, do a lot of orthodontics. I do a lot of orthognathic cases. Probably have 5 or 6 or 8 going at a time at any one time, which is enough for me. So because they're very complicated. And oftentimes I had my last case I saw today, I wish I had her thing. She said, you can put my case up if you want, but I didn't have her cone beam. But an orthodontist referred her to me. She had a broken jaw. She was seen by her famous oral surgeon, daddy back east, who made her anterior repositioning splint early on. Then she fell, broke her jaw. Now her face, I took a face right before I left, and in her midline, it looked pretty good, but all of a sudden her midline, she's off by, like her maxilla is off by a whole, tooth to the left. And she's got no joint, and she's in some funky splint with all these buildups. And I'm like, so of course the orthodontist's like, Tim, you take it. You do this ortho. I'm like, no, you do the ortho. I don't want to do this ortho. So we're fighting back and forth. It's like, wow, it's the first time an orthodontist actually begged me to take one of their cases. But we'll work on it together. So because it's going to be a fun case. But to see that, and she wanted to be treated with Invisalign. That was the other thing, And I love Invisalign. It's great product. But posterior open bilateral, moving teeth down with buildups on them with Invisalign, I don't think so. It's just not going to happen. So it's like that's when sometimes you got to learn to say no, and that's the hardest thing for us dentists because we all want to be the hero, and we got to learn to say no once in a while. And like Alex mentioned earlier, it's like sometimes you got to take that crazy person who's really got psychological issues and send them away. I have the luxury of being able to, send them back to their medical providers and work them into the system as, a little more delicately than just because they're already part, I get back to their PCP, let the PCP make the referral. So it makes it easier for me. But, I can be blunt, obviously. I have no problem being blunt. So what I want you to think about, and what I had worked out with this amazing slide presentation before my staff ruined it, that's how blunt I am. So I had this great video. I had the yoint video, and then I was going to follow it up with what do you think about it? You ever seen an old saltwater taffy machine? How that kind of bends and folds. So I had a video, of one of these great machines just to play, and there's some German guy in the background. I'm so mesmerized. So just because of that, and because it's Halloween, I want you to go home and I want you to chew on this saltwater taffy. Don't pull any crowns out. And I want you to enjoy that because the exact consistency when this warms up is going to be the exact same consistency. You can trade flavors if you want. The exact same consistency of a joint. I'll get more.